Okay, so welcome to this video. In this video, what we're going to talk about is diabetes mellitus and anti-diabetic drugs. Okay, now, the first thing I want to say before I do anything, before I even write the title, is I want to tell you about the two different types of diabetes. Okay, I want to contrast diabetes mellitus, which is what we're going to discuss, with the other type of diabetes, which is diabetes insipidus. Okay, and the reason I want to do this before I even write the title is that after I've discussed this, I am going to drop the mellitus. I'm not going to put that on anymore. I'm just going to refer to it as diabetes, and I assume that you are happy with the fact that when I say diabetes, I mean diabetes mellitus and not diabetes insipidus. Okay, right, so there's this other type of diabetes known as diabetes insipidus. Okay, so what do they share in common and what do they not share in common? Okay, so why are they both referred to as diabetes? What does diabetes actually refer to? It refers to excessive urination, okay, which is a symptom of both of these diseases, okay, but the cause of the excessive urination is very different between diabetes mellitus and diabetes insipidus. Okay, diabetes insipidus is a very, very rare disease compared to diabetes mellitus. And when most people say diabetes, they mean diabetes mellitus and not diabetes insipidus. Diabetes insipidus is caused by problems with antidiuretic hormone, okay, which stops your kidneys from excreting water and therefore is involved in stopping you urinating effectively. Okay, and when you've got problems with that, you therefore urinate excessively. Diabetes mellitus, this mellitus of the name here, this refers to sweet, okay? So this means sweet. And this refers to the fact that your urine in diabetes mellitus ends up tasting sweet because there is a lot of sugar in it, okay? So diabetes mellitus is all about problems with the control of blood glucose concentration, okay? And that's why you end up with glucose in your urine and why you urinate excessively and this urine is sweet tasting. So that's what diabetes mellitus refers to. However, I will now just call this diabetes. I will not put the clarifying mellitus anymore. Okay, and that's very commonplace. When most people talk about diabetes, they mean diabetes mellitus, not diabetes insipidus. Okay, if you were talking about diabetes insipidus, you would always put the clarifying insipidus on the end so that people knew what you were talking about. Okay, right. So, we are going to be talking about diabetes mellitus. We're not going to say anything more about diabetes insipidus. So now I'll write down the titles then. So, diabetes mellitus, and this is the last time I'll probably actually call it diabetes mellitus in the title, and anti-diabetic drugs. Okay, right, so what's the structure then for this video? Okay, right, so we're going to start off then with the actual definition of diabetes mellitus, or just diabetes, okay, and we're then going to move on to normal blood glucose homeostasis. So we're going to have a in-detailed look at how normal blood glucose concentration is controlled physiologically, okay, because only when we have a decent understanding of normal physiology can we understand the pathology that occurs in diabetes, okay, right. Then after that, what we're going to do is talk about the different types of diabetes mellitus. So we'll talk about type 1 diabetes mellitus, type 2 diabetes mellitus, okay. We'll also mention some rarer types of diabetes, for instance the monogenic forms of diabetes, particularly we'll look at MODY 2, okay, which is a nice example of a monogenic form of diabetes mellitus, okay. And then finally, what we'll talk about is gestational diabetes in that section on the different forms of diabetes. Then we'll move off those forms of diabetes and we'll move on to discussing the complications and the symptoms that can arise because of diabetes. Okay, now, whilst there are loads of different pathologies that can result in diabetes, they all have roughly the same consequences, okay? So all of the different types of diabetes mellitus, they're all going to have the same consequences, okay? So this final section we can discuss, because it's common to all of them basically. So we'll discuss the major symptoms of diabetes, we'll then move on to the acute complications of diabetes such as ketoacidosis, hyperglycemia, things like that. Then we'll move on to the chronic complications of diabetes, so macrovascular disease and microvascular disease, and then finally we'll talk about the anti-diabetic drugs. Okay, which are generally used to treat type 2 diabetes. Okay, type 1 diabetes is usually just treated with insulin replacement therapy. Okay, right then. So let's start off then with the definition of what diabetes mellitus is. So the first thing which I've alluded to in that opening sentence about the structure of this video is that there are different forms of diabetes mellitus. So there's type 1 diabetes mellitus, there's type 2 diabetes mellitus, there's these monogenic forms of diabetes mellitus, there's gestational diabetes mellitus, okay? So the actual cause of diabetes mellitus varies hugely, and in fact diabetes mellitus is not just one disease, it's a group of different diseases, okay, which all result in the same thing. And the characteristic feature that all of these different metabolic disorders have is that they result in hyperglycemia. Okay, so what does this mean? Well, this means too high blood glucose level. Now, throughout this video, I will be spelling hyperglycemia in the British English way of doing it, okay, where you put this A and E here. Now, I admit that it is a silly spelling, but I've been brought up with it and it's ingrained into me and I can't easily shake it off. Okay, if you are American, then just get rid of the silly A there and spell it the American way. Okay, right. So hyperglycemia then, this means too high blood glucose concentration. Glucose level within the blood is too high. Now importantly, diabetes mellitus is chronic hyperglycemia. It's not just hyperglycemia for an hour or so and then it goes. It's not even hyperglycemia just for a few days and then it goes. It needs to be long and persistent. It needs to be there continuously, basically. Months after months, basically. Okay, so it's chronic hyperglycemia, not acute hyperglycemia. Okay, and we'll stress the importance of that in a moment. Okay, so let's start off then with what the normal blood glucose concentration is. Okay, so normal blood glucose concentration is referred to as euglycemia. Okay, so U refers to normal, glycemia refers to blood concentration. So what is normal blood glucose concentration? Well, again, here's a place where the British way of doing things and the American way of doing things differs. And this time I'm going to use the American way of doing things mainly, and then I'll show you how to translate back to the British way of doing things. Okay, so basically in Britain, the way that you measure blood glucose concentration, the units in which you measure blood glucose concentration is different from the units that the Americans use to measure blood glucose concentration. Okay, so let me start off by giving you it in the American units. Okay, so normal blood glucose concentration should be between 70 and 120 milligrams per deciliter. Okay, so these are the units used in America. Now, the ideal blood glucose concentration is then in the middle here with around 90 milligrams per deciliter. That's the ideal blood glucose concentration. Now let me talk you through how you transfer into the other units of blood glucose concentration that are used in England. Okay, right. So the units that are used in Britain are millimoles per litre. Okay, which is usually just written as millimolar. Okay, so how do you convert from milligrams per deciliter to millimolar, basically? Well, firstly, what is a deciliter? Okay, well, deciliter is a tenth of a litre. Okay, so this is saying that in a tenth of a litre you're going to have 70 to 120 milligrams of glucose. Okay, so what would you then have in a litre? Well, you'd need to multiply it by 10. Okay, so if we say that our blood glucose concentration, will just arbitrarily denote that B, okay, if we want to convert it from milligrams per deciliter to millimolar, okay, firstly we're going to have to multiply it by 10, because we want to go from it being how much you've got in a deciliter to it being how much you've got in a litre. Okay, so firstly we'll need to multiply by 10, which will give us how many milligrams you now have in a litre. Now we need to convert milligrams into millimolar. So how do you convert milligrams into millimolar? Well, you use the formula that the number of moles is equal to the mass in grams, okay, in grams, divided by the molecular weight of the molecule. Okay, so if we're putting in the mass in milligrams, then the unit we'll get out here will be millimolar. Okay, so that's brilliant. So all we need to do is divide the mass in milligrams by the molecular weight, and we'll get the number of molecules in millimoles. Okay, so what is the molecular weight of glucose? Well, the molecular weight of glucose is 180. So let me just explain how you know that. The the formula for glucose is C6H12O6. Okay, so you've got 6 carbons, 12 hydrogens, and 6 oxygens. So all you have to do to work out the molecular weight of glucose is add up the molecular weights of all the carbon atoms here, all the hydrogen atoms here, and all the oxygen atoms here. Okay, so what are the molecular weights of each of those atoms that you've got within glucose? Well, the molecular weight of carbon is 12, the molecular weight of hydrogen is 1, the molecular weight of oxygen is 16. So all you have to do is times 12 by 6, because we've got 6 carbons, okay, that will give us 72. 1 times 12, because we've got 12 hydrogens, that'll give us 12. And then 16 by 6, because we've got 6 oxygens, that's 60 plus 36, so that's 96. Okay, and then if you add those together, if you add the 2 and the 6 together, that makes 10. If you add the 1 and the 9 together, that makes 100, so overall 110. Then just add on the 70, that'll take you up to 180. Okay, so that's the molecular weight of glucose. Okay, so what we now have to do is take this number, which is the blood glucose concentration in the units of milligrams per deciliter. We've times it by 10 to give us milligrams per litre, and we're now going to divide it by 180 to turn that into millimoles per litre, or millimolar. So that's the equivalent of just dividing by 18. Okay, so all you have to do to convert between the units of milligrams per deciliter, okay, and the units of millimoles per litre is divide by 18, or times by 18 if you want to go the other way. So to go from here to here, just divide by 18. To go from here to here, just times by 18. Okay, right. So when you divide these numbers by 18, then what do you end up getting? Well, when you divide 70 by 18, you end up getting around 3.9 when it's rounded up to 1 decimal place. So 3.9 millimolar. 2, when you divide 120 by 18, you get around 6.7, again, rounded up to 1 decimal place. And then when you divide 90 by 18, that one works beautifully, you get 5 millimolar. Okay, so roughly 5 millimolar is the normal blood glucose concentration in the units that are used in Britain. Okay, right, so that's another thing that's confusing, okay, but now we know all that we have to do to convert between one unit of blood glucose, the American unit of blood glucose, and the British unit of blood glucose is either divide or multiply by 18. Okay, right, so normal blood glucose then is within the range of 70 to 120 milligrams per deciliter, and the ideal value that you'd have is 90 milligrams per deciliter. Okay, that's euglycemia. So then, what is diabetes mellitus defined as then? Well, one way that you can diagnose diabetes is just by doing a fasting blood glucose test. So you're testing fasting blood glucose level, and I should say, when I say euglycemia, that means what your blood glucose level should be in the fasting state, basically. Okay, so when you have not just eaten, when you eat, then your blood glucose is going to go up slightly because you're absorbing glucose from the intestine. Okay, so this euglycemia will be disturbed physiologically whenever you eat. Okay, however, in the fasting state, this is what your blood glucose level should be around. Okay, so what you can do then is you can do a fasting state blood glucose test, and if you find that it's above this, that's what diabetes mellitus is. So, usually when a fasting blood glucose test is done, okay, you ask the patient not to eat anything for 8 to 10 hours prior to the blood glucose test. Okay, so 8 to 10 hours of fasting, and all you're allowed in that period is water. Okay, so you're only allowed to drink water. So usually what happens is you ask them to come in early in the morning and then just not eat anything before they come in. Okay, and then they can have breakfast after they've left. Okay, so that's the usual way of getting a fasting blood glucose readout. Okay, so if you get a fasting blood glucose level of greater than or equal to 126 milligrams per deciliter, that's what we define then as good enough for a diagnosis of diabetes mellitus. Okay, and if I put that in the other units, that's 7 millimolar basically. If you divide 126 by 18, you get 7. Okay, so greater or equal to this value, that's defined as diabetes mellitus. Okay, now, how do you know that this is not just an acute rise in blood glucose concentration? Now, when I say acute rise, I don't mean necessarily just a rise because they've eaten something, because they haven't done the fasting maybe. Okay, what I mean is a longer acute rise than that. I don't just mean a postprandial spike, as it's often called, okay, which means after eating spike in blood glucose concentration. I mean a rise that has occurred for a few days. Okay, now let me explain what might cause a rise in blood glucose concentration beyond normal euglycemia for a few days. Okay, well, stresses basically can result in blood glucose level rising acutely. So if you have a severe infection, for instance, okay, or if you suffer some trauma, okay, so if you have some sort of damage to your body, okay, or if you get some sort of burn, maybe. Okay, so something that causes the body stress, this will result in the release, an increased release of the stress hormone cortisol. Okay, so cortisol is released from the adrenal glands when the body is stressed. Okay, and what does cortisol do? Cortisol causes an acute hyperglycemia. Okay, so it causes blood glucose to be raised for the period whilst it's raised. So it causes acute hyperglycemia. So, you know, if the severe infection lasts for a few days maybe, okay, so let's say you've got a nasty bout of flu, then you're going to have elevated cortisol levels throughout that, and that's going to cause hyperglycemia which will last for the same amount of time as the cortisol is high for. Okay, so if you were to do a fasting blood glucose concentration when someone was suffering from a severe infection and therefore had high cortisol levels, then you might find that they were hyperglycemic, that their blood glucose concentration was above that. But that would not be diabetes, okay? Because diabetes needs to be a chronic hyperglycemia. You need to have it for months and months. You know, if you have it for a few days high, that's not really going to do you that much damage. Okay, for diabetes to start causing real damage, the acute and the chronic complications that we're going to see, it needs to be a chronic problem. Okay, right. So for this reason, tests to diagnose diabetes on blood glucose level must be repeated on multiple different days. Okay, it's not good enough just to do one test to diagnose diabetes. You have to then come back a few weeks maybe later and then have another test in order to confirm it. Okay, to make sure that it wasn't just an acute rise in blood glucose brought on maybe by one of these sort of stresses to the body. Okay, right. So, that's the basic definition then of diabetes mellitus. It's a problem in the control of blood glucose level, and it results in blood glucose being above the normal range for a chronic period of time. And chronically high blood glucose level is actually very damaging to the body, as we'll see later on. Okay, so before we go on then to discuss the different types of diabetes, what I want to discuss is the normal way that blood glucose concentration is maintained within the body. Okay, so that's what we'll move on to now. So, glucose homeostasis then is our next topic. Okay, so normal fasting blood glucose concentration then is maintained at between 70 and 120 milligrams per deciliter, okay? But we'll take the ideal value. Let's say the ideal value is 90 milligrams per deciliter, and that's what we'll say we're aiming for, okay? Which, remember, is 5 millimoles. Okay, right, so how is this achieved? Well, there's two parts of glucose homeostasis that we need to discuss. Firstly, we need to discuss how it's maintained at that in the fasting state. Okay, so when you haven't eaten for, let's say, 3 or 4 hours, okay, that's what we'll define as the fasting state. And then we need to look at what happens when you feed, okay? How does the glucose homeostatic mechanisms change when you feed to take account of the fact that now loads of glucose is coming in from the intestine? Okay, so we'll start with how is glucose concentration in the blood maintained during the fasted state. Okay, so let's say you're in the fasted state. Okay, right. So, in the fasting state, we can rule the intestine out, okay? We'll say there's no glucose coming in from the intestine. So what we now need to balance then is the amount of glucose that is being taken out of the blood by organs such as the brain, which are going to be using it for metabolism. And then we need to balance also the amount of glucose going into the blood from the liver. Okay, so basically what's normally happening then is, let's draw the blood here. Okay, so this is going to represent a blood vessel here. Okay, and I'll colour this in red here. Okay, and it's going to have glucose within it, and certain organs, which we'll represent as the brain here, okay, are going to be taking glucose out of the blood all the time so that they can use it. So glucose is going to be leaving the blood and going to certain organs such as the brain to be used. Okay, so how are you going to maintain constant blood glucose concentration? You've not got glucose coming into the blood via the intestine, so we can rule the intestine out. That's not going to be supplying glucose in. So where does the glucose come into the blood? You know, if we don't have a source of glucose, the brain's just going to take all the glucose out here, and then blood glucose level is going to plummet, and then the brain's not going to have any more glucose being delivered to it. So how do we maintain a constant blood glucose concentration in the fasted state? Well, basically, the liver is responsible for this. The liver is going to be putting glucose in. So I'll draw the liver here. Okay, like so. So this will represent our liver here. Obviously, it's not an anatomical picture, it's just a physiological picture. So here's the brain, and it's not just the brain that will be using glucose, many other tissues as well, but we'll use the brain as the sort of archetypal tissue that uses glucose. Okay, and the liver is going to continuously be putting glucose into the bloodstream in the fasted state, and that's how you maintain a constant blood glucose concentration in the fasted state. Now, where is the liver getting this glucose from? Okay, well, there are two ways the liver can get glucose. Firstly, the liver has stores of glucose, okay, within it. The huge number of cells that you have within the liver have a reservoir of glucose stored as a molecule known as glycogen. So let me just explain this. So basically, glycogen is a polymer of glucose. Okay, so if I represent glucose as this little hexameric structure here, okay, so this will represent glucose. We're not going to actually draw out the molecular structure of glucose, it's not necessary. Okay, but just for a picture, I'm going to represent the glucose as a hexamer, which is roughly true. Okay, it is a hexamer. It does have a hexameric ring, a 6-membered ring. It's slightly more complicated than just being a hexamer of carbon like this. It is in fact only got 5 carbons in this ring and 1 oxygen atom. Okay, but we'll represent it as a hexamer just for want of a better shape to represent it as. And what you can then do is you can add more glucose molecules onto this, okay, to start forming a polymer of glucose, like so. So glucose molecules can end up polymerized together like this. So each one of these hexamers is representing, hexagon, that's the word I'm looking for, not hexamer. Each one of these hexagons is representing a glucose molecule. Okay, right. Like so. So when you make a glucose polymer like this, this is known as glycogen. Okay, and the liver cells, the hepatocytes within the liver, have glycogen molecules stored within them, and these are the form in which glucose is stored within hepatocytes. Okay, so what can happen is the liver cells can break down the glycogen stores that they have, okay, and release the glucose monomers here, okay, into the blood. Okay, so this is one of the ways that the hepatocytes produce glucose. Okay, and this is known as glycogenolysis. Okay, so glycogenolysis. Now, lysis means to split apart. Okay, so that's why this is a relevant name. Okay, so glycogenolysis is the breakdown of glycogen, which is this polymer of glucose monomers, okay, stored within hepatocytes, into its individual glucose monomers, which can then be released into the bloodstream. So that's one of the ways that the liver cells are producing glucose, which they can secrete into the bloodstream when you're in the fasted state. Okay, the other option that they have available to them is what's known as gluconeogenesis. Okay, now we're not going to go into the details of the molecular pathways of gluconeogenesis or glycogenolysis. Okay, I'm just going to give you the basic concept of what each of these are. Okay, so gluconeogenesis involves the conversion of certain amino acids into glucose. Okay, so the amino acids which can be converted into into glucose are known as glucogenic amino acids. Okay, so glucogenic amino acids. So certain amino acids known as glucogenic amino acids can be converted by pathways known as gluconeogenic pathways into glucose. And this is another thing that is occurring within the liver in order to produce glucose that can then be secreted into the bloodstream in these fasting periods. Okay, so overall then, in the fasting period, your peripheral tissues are removing glucose from the blood to be used, okay, and therefore you're having to put glucose into the blood, otherwise blood glucose level would fall, okay, and it's the liver which is responsible for doing this, okay, and the hepatocytes have two places that they can get glucose from. They can either break down glycogen stores into glucose, a process known as glycogenolysis, or they can use gluconeogenesis, in which they take glucogenic amino acids and they convert them into glucose monomers, which can then be released into the bloodstream. Okay, so those are the two pathways by which hepatocytes can produce glucose. Now, how do the hepatocytes know to be doing this? What triggers them to be doing this? Okay, well, you might think that maybe the hepatocytes are just measuring blood glucose themselves and saying, oh look, it's starting to fall, we better be doing these pathways. But in fact, there are two very important hormones controlling the behavior of hepatocytes. And it's these hormones that I want to talk about now. Okay, so let's move on to this other side. So the two hormones I want to talk about are insulin and glucagon. Okay, which are both secreted by cells of the islets of Langerhans. Okay, but we'll come on to that in a moment. For now, I just want to talk about what insulin and glucagon actually are. So, we'll begin with insulin. So, insulin is it's a protein. It's made out of polypeptides, okay? Now, it looks, when you first draw the structure of insulin, it looks as though it's two separate polypeptides stuck together, okay? And it is two separate polypeptides stuck together, but the two separate polypeptides that are stuck together originally came from a single polypeptide which was made from a single gene, okay, and then processed. So I just want to explain a little bit about this. So let me firstly then show you the structure of insulin. So insulin has two separate polypeptides which are joined together by two disulfide bonds. Okay, and these two separate polypeptides of insulin are known as the A chain, shown here. Okay, so this is supposed to be the N terminus and this is supposed to be the C terminus of the A chain. So I'll colour the A chain in purple here. And then the second polypeptide of insulin is known as the B chain. Now the B chain is bigger than the A chain, so here is the B chain. So I'll add the word chain in as well. So this is the A chain and this is the B chain of insulin. So it looks as though we've got two separate polypeptides here, which we have, okay, that have been stuck together, but you wouldn't know from this that they had come from a previous bigger polypeptide that was made from a single gene. Okay, and that's an important point to understand. So, holding these two together then, there are two disulfide bonds like so. Now, let me explain in more detail then the fact that we first make a single polypeptide from a single gene, which is then going to be cleaved up into these two separate chains, which then end up binding together. Okay, so the initial thing that you produce when you're producing insulin is something known as Pre Pro Insulin. Okay, so let me show you the structure of Pre Pro Insulin. So here's the amino terminus of Pre Pro Insulin. Then you've got a little portion that's going to go, which is known as the signal peptide. Okay, then you've got the B chain portion here. Okay, and then what happens is it ends up folding round like so. Okay, and the A chain portion is down here, which is now already attached to the B chain portion here. Okay, so when you make Pre Pro Insulin, it folds up, and the A chain and the B chain end up binding to one another. So here is the A chain portion here. Okay, so I'll colour in the A chain portion once again in vivid purple here. Okay, so this, in fact I might just as well just colour it in completely. Okay, and I'll colour in the B chain once again in orange here. So these other bits of the Pre Pro Insulin, the signal peptide and then that large loop between the B chain and the A chain, those bits are going to be cleaved out. Okay, so let me now discuss these different portions of Pre Pro Insulin. So this portion prior to the B chain here, which I've coloured in green, this is known as the signal peptide. Okay, and this is responsible for telling the cell's machinery that this Pre Pro Insulin needs to go down the pathways for being secreted basically from the cell into the extracellular fluid. Okay, but once it's done that, it can be cleaved off and it's no longer needed. Okay, then the portion in between the B chain here and then the A chain round here, that is known as C-peptide. Okay, the C-peptide. This is actually also secreted along with the insulin, okay, but its function we're not really going to go into. Okay, so what then happens in the processing of Pre Pro Insulin is firstly you cut off the signal peptide here, okay, to end up with the B chain, the C peptide and the A chain. Now that is known as pro-insulin. Okay, so firstly you cut off the signal peptide and you go from being pre-pro insulin to being just pro-insulin, and then when you cut out the C peptide from pro-insulin, that then takes you to the final insulin. Okay, so that's just a little bit of information about then the structure of insulin. Okay, let's now talk about the structure of glucagon, and then we'll talk about where they're going to be secreted from and how they're going to act on peripheral tissues and how they're going to control the liver's function in this fasted state, and that they're going to make it activate gluconeogenic pathways and also glycogenolytic pathways. Okay, so on to glucagon then. Okay, I've got rather less to say about glucagon. Again, it is just a small little polypeptide. Okay, so both insulin and glucagon are both peptide hormones. Okay, so to represent glucagon, all I'm going to draw is a single line here to represent a polymer, okay, a polymer of amino acids, also called a polypeptide, and it's rather more boring than insulin. It's just, you know, it doesn't have two separate chains bound together, it is just one little polypeptide. Okay, so I'll colour it in turquoise. So both of these hormones are just little peptides, basically. Okay, right, so let's now talk about where insulin and glucagon actually come from. So they come from the endocrine portion of the pancreas. Okay, so let me just discuss the anatomy of the pancreas then with you. Okay, and then I'll talk about the fact that most of the pancreas is exocrine, but a certain portion of the pancreas is endocrine. Okay, so let's draw a little picture of the pancreas here then. So the pancreas extends down here, it has a little process off like that, okay, and then goes back like this, kind of looking like a hockey bat. Okay, right, so this portion of the pancreas over here, which is on the left hand side of the body, this is known as the tail of the pancreas. This portion in the middle is known as the body of the pancreas. Okay, and this portion up here is known as the head of the pancreas. Finally, this little extension off over here, forming like the hook here, okay, through which many blood vessels move through this little process here, well, this little gap here. Okay, this is known as the Untitled process. Okay, right, so let me colour in the pancreas in, what colour should I have it in? I'll have it in blue. Okay, right, so that's all the anatomy that we're going to go into of the pancreas, just so that I've got a picture to draw whenever I need to draw the pancreas. Okay, then what I want to discuss is the fact that most of the pancreas is exocrine. Now, what do I mean by exocrine? Okay, well, the word exocrine, exo means exterior of the body. Okay, crine refers to hormones, okay, or secretions. Okay, so this means that the pancreas is going to be secreting things onto the external aspect of the body. Okay, so the exocrine portion of the pancreas is secreting enzymes into the lumen of the gastrointestinal tract. Now remember, the lumen of the gastrointestinal tract is viewed as being outside of your body. You are viewed as being a donut-shaped structure, okay, and you have a tube going down the middle of you, but that's still viewed as the outside of you, okay. So when you put in food into your mouth, it's going through a tube through you, but it's not actually going inside of you. Okay, the nutrients obviously will be absorbed into the inside of you. Okay, so the exocrine portion of the pancreas is secreting digestive enzymes into the lumen of the gut, okay, and therefore is secreting things onto the exterior surface of the body, and therefore is an exocrine gland. Okay, so most of the pancreas is made up of exocrine portions. However, dotted amongst all the exocrine structures, you also have endocrine structures. Now, what does endocrine mean? Endo means the inside portion of the body. Crine again means secretory. So endocrine portions are going to be secreting things into the inside of the body, into the blood. Okay, so the pancreas does contain small portions that are endocrine rather than exocrine, and these consist of cells that are all bundled up into little balls, which are scattered amongst all of the exocrine tissue. Okay, so let me colour in these little balls. So these little areas of the pancreas, I'm now colouring in pink. These are the little areas where you have endocrine cells which are going to be secreting hormones into the blood. Okay, so these little balls of cells scattered amongst the exocrine portions of the pancreas, they are known as islets of Langerhans. Okay, now, islets of Langerhans contain many different types of cells, but the two main ones, as far as we're concerned, are beta cells and alpha cells, or I should probably say alpha cells and then beta cells. Okay, so let me draw a little picture of an islet of Langerhans then. Okay, so if I draw an islet of Langerhans here, it's going to be full up of loads of different types of cells here. Okay, so these are the individual cells of the islets of Langerhans. The entire thing is the islets of Langerhans, or is an islet of Langerhans, the singular there. Okay, and it contains multiple different types of cell in it, but the two that we're going to be interested in are alpha cells, shown here in blue, and then we'll have some beta cells here. Okay, now I'll leave that one plain because there are other types of cells in the islets of Langerhans as well. Okay, it's just we're not going to need them in this discussion. Okay, right, so the alpha cells then secrete glucagon, okay, and the beta cells secrete insulin, okay. Now in the fasted state, your blood glucose level will be at the euglycemic level, okay, and at that euglycemic level, the alpha cells are activated to release a lot of glucagon. So they're going to be releasing a lot of glucagon, and the beta cells at that euglycemic level are going to be not releasing that much insulin. So they're going to be releasing only a tiny little portion of insulin. So insulin is going to be very, very low, and glucagon is going to be high, and this is at the euglycemic level. Okay, so both alpha and beta cells are sensitive to glucose concentration. When glucose concentration is euglycemic, okay, so not high basically, the alpha cells are going to be activated to release a lot of glucagon, and the beta cells are going to be inhibited from releasing insulin. And they're not going to be releasing no insulin, they're just not going to be releasing particularly large amounts of insulin. So, at the euglycemic level, insulin is low and glucagon is high, and it's this that causes the liver to start this activity of releasing glucose into the blood so that you maintain euglycemia. Okay, this mixture of glucagon and insulin, this high glucagon with low insulin, this is perfect for setting the liver's secretion of glucose to exactly the right level that you need to maintain euglycemia. Okay, so let me tell you what glucagon and what insulin's effects are on the liver then. Okay, so we'll start with glucagon then. Glucagon acts on receptors on the liver, and I suppose I actually need to tell you about the receptors. Okay, so these are hormones that are being secreted from these cells into the blood. How are they going to act on liver cells? Well, both of them have receptors on the surface of hepatocytes. Okay, so if I draw a hepatocyte here, okay, so this represents the membrane of our hepatocyte, so it's a single cell of the liver. Okay, it will have on its surface receptors for glucagon. Now the receptors for glucagon are G protein coupled receptors. Okay, so they have the 7 membrane spanning alpha helices. Okay, so this is a glucagon receptor. Okay, now we are not going to go into the details of the downstream pathway of the glucagon receptor or even the insulin receptor. Okay, it is a fascinating area, obviously. Okay, but it would take me hours to explain the downstream pathways of the glucagon receptor and the insulin receptor, and I don't actually think it's that important that you know the downstream pathways of the insulin receptor or the glucagon receptor. Okay, I think understanding the system, how insulin and glucagon work as a system to modulate glucose blood glucose level is more clinically important than knowing the actual intracellular signaling pathway by which it produces certain effects on cells. Okay, so we're not going to do the molecular details of the signaling pathways. Okay, we're just going to draw the receptors on there because the receptors are an important concept. The concept that on this external aspect of the cell you have this receptor that the molecule binds to, and then it triggers some intracellular cascade which then causes the output effect. Okay, so here then is our glucagon receptor, which is a G protein coupled receptor here. Okay, and then you've also got receptors for insulin. Now the receptors for insulin are a little bit more unconventional. Okay, they are receptor tyrosine kinases, but unlike most receptor tyrosine kinases, which are not already dimerized, okay, most receptor tyrosine kinases require their ligand to bind and then they dimerize. Insulin receptor is already dimerized. Okay, so the insulin receptor consists, again, of 4 separate polypeptides. However, the two different types of polypeptides that are used here are made from a precursor polypeptide, similar to the way that insulin was made from a precursor polypeptide. Okay, so let me draw this and then I'll go into that in a little bit more detail. Okay, so basically, here are our 4 polypeptides. The 2 that span the membrane are both known as beta subunits. Okay, so I'll colour them in. So in red here, these are the beta subunits of the insulin receptor. And then the 2 on the external aspect up here in green, these are the alpha subunits of the insulin receptor. So you've got the 2 alpha subunits. So these 2 alpha subunits will be identical and these 2 beta subunits will be identical. Now, this beta subunit will be attached to this alpha subunit, this beta subunit will be attached to this alpha subunit, and then the 2 alpha subunits will be bound together to make the full insulin receptor here. Okay, right. So, what I was saying previously was the fact that you firstly synthesize a precursor polypeptide which contains both the alpha subunit here and the beta subunit, and then that's cleaved up to make a separate alpha and a separate beta subunit, which then bind together. And then another alpha beta dimer here will then dimerize with that alpha beta dimer to make the full tetramer here, which is made up of 2 alpha subunits and 2 beta subunits. Okay, and now what's going to happen is an insulin molecule is going to go and bind between these 2 alpha subunits here, and it's only one insulin molecule that needs to bind. Okay, so one insulin molecule binds here, one glucagon molecule binds here. Okay, and again, this triggers intracellular signaling cascades, even more complicated than the intracellular signaling cascades of the glucagon receptor, because this is a receptor tyrosine kinase, so it's horrendously complicated how many different cascades it activates. Okay, so what we need to understand then is that hepatocytes have these receptors for these important hormones on their surfaces, okay, and that when these hormones bind to them, these receptors, it triggers intracellular signaling cascades that are going to have some effect on the cell's output. Okay, right, so what does glucagon receptor do once it's been activated then? Well, it promotes gluconeogenesis, okay, so it activates the gluconeogenic pathways, okay, so it makes gluconeogenesis go up. Okay, it also activates glycogenolysis. Okay, so the 2 things that we said the liver should be doing when we're in the fasted state. Okay, so glycogenolysis is also going to be activated. The insulin receptor is going to do the exact opposite. Okay, the insulin receptor is going to inhibit gluconeogenesis. It's going to stop gluconeogenesis from occurring. Okay, so gluconeogenesis is going to go down, and it's going to cause the building of glycogen. Okay, so remember, in glycogenolysis, we were breaking down glycogen, this polymer of glucose molecules, into the individual monomeric glucose molecules. In the opposite process, glycogenesis, you take glucose monomers and you build glycogen polymers. Okay, so insulin receptor activates glycogenesis. Okay, so here is gluconeogenesis goes up in response to glucagon, it goes down in response to insulin. Okay, glycogenesis is initiated by the insulin receptor, whilst glycogenolysis is initiated by the glucagon receptor. Okay, so these 2 things do the exact opposite, basically. So, usually in the fasted state, we've got glucagon high, insulin low, which means we're getting lots of activation of this receptor, less activation of this receptor. Okay, so this is promoting gluconeogenesis, this is saying, okay, tame it down a little bit, okay? But overall, you have a certain amount of gluconeogenesis. Okay, this one is taming it down, and that's an important point to understand. If you were to take out this little amount of insulin that you've got at the normal fasting glucose concentration, okay, then the hepatocytes would end up overactivating gluconeogenesis, because this one is taming down the glucagon signaling. Okay, so gluconeogenesis is on, but it's not on as much as the glucagon would like it to be, okay, because the insulin is taming it down and keeping it at a reasonable level, okay, and that's going to be really important to understand when we come on to diabetes later on. Okay, right, in addition, glucagon is activating the breakdown of glycogen and the release of glucose into the blood, whilst insulin is taming it down. It's saying, okay, no, stop that a little bit, we'll make a little bit at the same time to counteract what you're doing. Okay, so again, the net effect of all of this is that you are releasing glycogen into the blood as glucose monomers, okay, but the effect is tamed by the insulin. Okay, so if you were to take out this small amount of insulin that you have here, the glucagon would overstimulate the hepatocytes now. Gluconeogenesis now would be too high because it wouldn't be opposed by the insulin anymore, and glycogenolysis would be too high because it wouldn't be opposed by the insulin anymore. Okay, and you chuck far too much glucose out into the blood, more glucose than the peripheral tissues were actually using. Okay, so you break the equilibrium. Okay, remember that we're maintaining an equilibrium here. We want the peripheral tissues to take up glucose. Okay, that will cause blood glucose to fall, but we don't want that, so what the liver is doing is it's tipping into the blood the same amount of glucose as the peripheral tissues are taking out. If the balance was broken because of the loss of insulin, then the hepatocytes would start chucking out far too much glucose, and that would mean the glucose wouldn't all be removed by the peripheral tissues, and it would start to build up in the blood, and you'd start to get hyperglycemia in the fasted state. And that is actually what's going to happen in diabetes mellitus. Okay, right, so we'll call it there for this video, and in the next video what we'll do is move on to blood glucose homeostasis in the in the fed state. We'll have a look at what happens when you have just eaten and your blood glucose is now going to go up.